Thanks, Dr. Gleave. So today I'll be talking about techniques using grafts and flaps for male anterior urethral reconstruction. So the open surgical repair of urethral strictures has changed dramatically in the last several decades. Today, nearly all urethral stricture disease can be repaired in a single-stage operation, except in a few circumstances. However, no single surgical method is good for all repairs, so a complete surgical knowledge of all the different techniques is required before performing urethroplasty. The objectives of this talk are to review the presentation, etiology, diagnosis, and relevant anatomy of anterior urethral strictures, to review various surgical techniques for correcting these strictures with substitution urethroplasty, and to present literature on success rates of various techniques and to outline some recommendations. So the urethra is traditionally divided into anterior and posterior parts. The anterior urethra is surrounded by the corpus spongiosum. It includes the bulbar urethra, which is enclosed by the bulbospongiosus muscle, and the penile urethra that runs from the distal margin of the bulbospongiosus to the fossa navicularis and external meatus. The anterior grade arterial blood supply to the urethra is sourced from the internal pudendal artery, which gives off branches to the urethral artery and bulbar artery, which then run the length of the penis and go to the glands where they anastomose with the dorsal artery. The retrograde blood supply comes from the venous system, and again you have the urethral and bulbar veins that run alongside their respective arteries, and then they join in the bulb to form a common urethral bulbar vein, which then drain into the internal pudendal vein. So the history of urethral stricture disease is quite far-reaching, back to 600 BC, where Sushruta, who was an ancient physician from India, went on to describe many procedures, including those for hydrocelectomy, some prostate surgeries, as well as bladder stones. He was also the first to describe the management of stricture disease, and he said, in a case of a urethral stricture, a tube open at both ends, made of, in this case, iron, wood, or shellac, should be lubricated with clarified butter and gently introduced into the urethra, and then thicker and thicker tubes should be duly introduced every third day. This was the first official description of urethral dilation, but it's actually been found that urethral dilators dating back to 3000 BC have been found in the tombs of pharaohs, apparently to allow them to continue to dilate their strictures in the afterlife. Yeah. So the ancient people have always known that a stricture meant having it for life, and for those in whom dilation failed, there were only three alternatives. The first was to hope for the development of a urinary fistula to allow for drainage, and the other two options were quite dangerous at that time, and that was to perform an external urethrotomy or a cystotomy. And this was all that was really readily available until the pioneering efforts in the 50s and 60s developed the concepts of urethroplasty, which still to this day is driven by two principal surgical procedures. One is anastomotic urethroplasty for short strictures, and the second is substitution urethroplasty for longer strictures, and I'll be discussing these various techniques. So in most cases, patients with urethral stricture disease are referred to their urologist for lower urinary tract symptoms in the category of failure to empty. Urethral strictures are obstructive, so they can include the symptoms seen here: hesitancy, intermittent stream, decreased stream, nocturia, frequency, pain with voiding, and even urinary retention, as we see in the emergency department sometimes. Alternatively, the stricture can sometimes be identified due to a failed catheter placement. So many types of strictures exist, including iatrogenic strictures, so those would be caused by catheterization, instrumentation, prior hypospadias repair, for example. There's infectious or inflammatory strictures, for example, from gonorrhea or lichen sclerosis. Traumatic strictures from straddle injuries or pelvic fractures, and then congenital as well as idiopathic strictures. With respect to penile strictures, about 15% are idiopathic, the majority being iatrogenic or inflammatory, and then 5% related to trauma. And then for bulbar strictures, again 40% idiopathic and iatrogenic, 10% inflammatory, and 15% are traumatic.
Hilary, that's really sort of worldwide,
Mm-hmm.
because I think if you look in Western world, its highest predictor is having seen a urologist before.
Yeah, that's right. That's right for iatrogenic strictures, for sure. Yeah. So all strictures result from an injury to the epithelium of the urethra or the underlying corpus spongiosum, which ultimately causes fibrosis during the healing process. The pathological changes associated with strictures are that the normal pseudostratified columnar epithelium is then replaced with squamous metaplasia. And next we see what's been described as the creep phenomenon, where you have small tears in this metaplastic tissue from the high voiding pressures of urine behind it, and then that causes a fibrotic reaction in the spongiosum, and the stricture can actually creep proximally and lengthen. At the time, this fibrosis can be asymptomatic. However, over time, the fibrotic process can progress until patients do start to complain of voiding symptoms. The complications from untreated stricture disease carry significant morbidity, which has been documented in the literature. Here, this is most recently from an article in Nature, and complications include, as you see, so a thick wall bladder, retention, prostatitis, epididymoarchitis, hydronephrosis, periurethral abscess, or stones.
Excuse me, how do you define prostatitis in these cases? Is that a true bacterial prostatitis?
In most of the cases it is, yeah, from the high voiding pressures of the urine.
I saw a lot of strictures that maybe I wasn't aware of it, but I didn't see a lot of prostatitis. 50% sometimes.
Yeah.
Yeah, I don't think the strictures really blow their upper tracts like BPH does.
No.
Like,
No.
let's say 20% hydronephrosis, you just don't see that.
Well, that's the cases that we got. Some of them were, the ones we started, Jamie and I started learning on, were the vets from World War II, and they're almost all gone real stricture. So, occurring under the line of duty, of course. And but they were not associated with prostatitis, to my knowledge. Interesting.
Yeah.
Where'd you get that?
This is from an article in Nature Reviews. Yeah. All right.
Does anyone else have seen prostatitis?
Hilary, did that paper comment on the significance of the stricture itself, length, or these patients were in complete retention, and that sort of thing? I agree with Dr. Patterson.
Yeah. Yeah, and often these
They blow their
patients
bladder,
are.
but they don't.
Yeah.
They don't blow their upper tracts like BPH.
Yeah.
So Lauren, that might include UTIs.
Yeah, it's prostatitis is such a grab bag of stuff. Anyway, thanks.
No problem. So preoperatively, a urological history and physical exam need to be performed. And on physical exam, palpation of the anterior urethra can help identify the depth and the density of the stricture. Often patients will have an obstructive or meso-shaped urethral flow, as seen here by the red arrow, and this is reflective of their fixed obstructive process. They may also have a high post-void residual, and a urinalysis should also be obtained to rule out infection. So to properly assess stricture length and location, it's essential to obtain the gold standard of urethral imaging, which is the retrograde urethrogram, and often reconstructive specialists in urology do perform their own retrograde urethrograms in order to ensure that they are satisfactory to their liking. Radiographic technique and proper oblique positioning are critical as to not underestimate the length of the stricture. And typically, narrowing of the lumen is evident at the site of the stricture with a dilation of the urethra proximal to the stricture. The voiding cystourethrogram is another diagnostic tool, and it's essentially an anterograde urethrogram. It's not routinely ordered, but it can be useful in a couple of situations. And the first is for an obliterative stricture where contrast just doesn't pass through in the retrograde fashion, so you can pass contrast through the suprapubic tube and then take the urethrogram. This combined with a retrograde urethrogram can be helpful to delineate the entire length of the stricture. The second situation is in distal penile strictures where it can be difficult to image those in a retrograde fashion, but otherwise for most urethral strictures a retrograde urethrogram is sufficient. Cystoscopic evaluation is also important. You can use a pediatric cystoscope, size 6 French up to 9 French, or even a semi-rigid ureteroscope to examine the stricture through the urethral meatus. Or alternatively, you can do it in an anterograde fashion with through a patient's suprapubic access. So to briefly discuss urethral dilation, there's several methods for this that exist, but overall there has been a prospective randomized control study by Haynes comparing dilation versus DVIU, and it found no significant difference in stricture-free rates at 3 years, and no difference to the median time to recurrence. As we all know, DVIU uses a cold knife to make an incision to release the stricture scar tissue, and then allows it to heal by secondary intention. There's currently really no consensus on whether to leave a catheter or not. Most people do, and as well no consensus on how long to leave the catheter for. Success rates vary widely in the literature for DVIU, and they range from 10 to 80%, usually looking at depending more on their time of follow-up. But ultimately, long-term overall success has been reported at 30%. And if a patient develops stricture disease after these techniques, the long-term success rate of repeating them does essentially approach zero if urethroplasty is not undertaken. They will recur. So with DVIU, recurrence rates vary with stricture length and are higher with longer strictures, as to be expected. The risk of recurrence at 12 months is 40% for strictures under 2 centimeters in length, 50% for 2 to 4 centimeters, and 80% for strictures longer than 4 centimeters. Recurrence rates also vary with stricture location, and in this long-term follow-up study at 18 months for 225 patients after their first DVIU, they found that 58% of bulbar strictures recurred and 84% of penile strictures recurred. Likely the difference is due to a more robust blood supply in the bulbar urethra.
Was recurrence defined as in this second procedure?
I will
Or
get to
just-
that, for sure. I will get to that. So repeat urethrotomy is known to have progressively worse outcomes, and essentially, like I said, a 0% success rate has been reported after the third DVIU. So when it's been decided to proceed with urethroplasty, an interval of 3 months is usually preferred between the last urethral manipulation and formal urethroplasty. The insertion of a suprapubic tube is often based on the individual surgeon, whether it's only inserted for patients in retention or who are having severe difficulties voiding, or if everyone should get a suprapubic tube with the concept of urethral rest. Urethral rest is proximal urinary diversion to allow for resolution of any areas of inflammation and to also allow the full extent of the stricture to declare itself, because it can be kind of forced open with high voiding pressures. So now to discuss the surgical techniques. There are 3 major categories for surgical correction. They are anastomotic urethroplasty, augmentation urethroplasty, and onlay urethroplasty. So to begin, during anastomotic urethroplasty, the stricture is excised transversely at each end of the urethra and then sutured back together over a Foley catheter. Lateral mobilization along the urethra away from the corpora is key, and it must be taken as distally as possible in order to minimize any tension. Success rates in the bulbar urethra have been reported to be 91 to 95% in 2 large series. However, the anastomotic procedure can only be performed in the bulbar urethra for a stricture 4 centimeters or smaller in length, and it also depends on other local tissue factors, which I'll talk about. If anastomotic urethroplasty is deemed not an option, either due to excessive length or location in the penile urethra, where this procedure does carry a significant risk of core D as a complication, augmentation or onlay urethroplasty can then be performed. So this brings us to grafts versus flaps. So as a quick review, a graft is a tissue that does not have its own blood supply and relies on the host bed for passive diffusion of nutrients in the first 48 to 72 hours through a process called imbibition, followed by ingrowth of vasculature from the host bed called inosculation, and then finally new growth of blood vessels and neovascularization. Success of a graft is termed graft take, and in urethral reconstruction, extragenital skin grafts are almost always preferred, especially with lichen sclerosis, where there can be subtle changes to the penile skin. So the most common example is the Buccal mucosal graft, which I'll talk about, but you can also use lip or linguinal grafts. A flap is mobilized tissue that maintains its original blood supply, and when we talk about the success of a flap, we use the term flap survival. The most common example would be a penile skin island flap based on a pedicle of dartos and its own blood supply. Skin flaps were pretty popular in the 80s and 90s for urethral reconstruction, but they've gradually been replaced by grafts because they are technically easier, have little morbidity, and can be used throughout the urethra. In terms of classification of flaps, there's many different systems, but functionally speaking, if the blood supply is known, it's termed an axial flap, and if it's not known, it's termed a random flap. So now to talk about the penile skin blood supply. So for penile skin flaps, the blood supply comes from the superficial external pudendal artery. This artery branches off the femoral artery and gives branches to the anterior scrotum as it crosses the spermatic cord and enters the base of the penis as posterior lateral and anterior lateral axial branches. The branches then interconnect with each other and form an arterial network in the dartos fascia, which has conceptually been described to think of the dartos like a trellis and then the blood vessels like vines weaving through it. This vasculature is the blood supply to all penile skin flaps, so it's an axial flap with a known arterial supply. And this makes the flap quite advantageous as it can be mobilized widely, transposed fairly aggressively, provided the basolateral aspects are preserved. So this brings up the Robin Hood principle of stealing from the rich to pay the poor, but only when the rich can afford it. Using what the body has to reconstruct a deficit is essentially robbing the bank, and the goal is to achieve ultimate efficiency and, in a sense, to try to get something for nothing. It's extremely important to not make the mistake of merely advancing tissue to a deficient area unless this can be accomplished without tension. Tension compromises the blood supply of the advanced tissue, and ultimately it will result in flap failure. It must be recognized and prevented, and ultimately avoided in order to achieve the greatest chance of success. So augmentation urethroplasty. This refers to repairing a urethral stricture with one of the aforementioned flaps or grafts and entails 3 different surgical methods. The first is stricture excision and replacement of the removed segment with a graft or flap. The second is stricture excision and replacement of the segment with an augmented anastomosis on one side and a graft or flap on the other side. And the third is stricture incision or urethrotomy, either ventrally or dorsally, and then patching this with an onlay flap or graft. So to begin talking about flaps, there are 2 techniques of penile skin flaps for urethral reconstruction. The first is the Orandi technique, which is a longitudinal ventral penile skin flap on a lateral pedicle. And the second is the Mechanich technique, or the transverse circular distal penile skin flap. So in the Orandi technique, a midline ventral penile skin incision is made over the region of the stricture and is extended into healthy urethral tissue proximally and distally. To create the flap, you make a fusiform vertical oriented incision just lateral to your midline incision, and then dissect this out laterally to create the blood supply. So the skin incision is deep enough to split the dartos into 2 layers. So you have a lateral vascular pedicle, which will supply the overlying skin, and then the medial vascular pedicle to supply the flap. The medial side of the flap is then sutured to the lateral edge of the urethral border and then rotated over the midline, and the other edge is sewed to the corresponding urethral border, and the skin is closed over top for secondary closure. Advantages of this flap is it's relatively easy to construct and has no overlapping suture lines to minimize the risk of ureterocutaneous fistula formation. The major disadvantage is that hair is often present at the proximal aspect of the penile shaft, which does limit the flap length to roughly 5 to 9 centimeters. And as well, the lateral vascular pedicle is relatively short, so the flap can only be used in the penile urethra. Overall success rate of this in the literature has been reported to be about 75.6% at 12 months. The Mechanich technique is a more technically meticulous flap. It requires a transverse circular distal penile skin flap to be formed. It can be used for long anterior urethral strictures and provide up to 15 centimeters in length. The skin is hairless, and the suture line will be the same scar as a circumcision. So the transverse circular flap is outlined as seen by the pink flap of tissue on this picture, and usually it's between 2 and 2.5 centimeters wide. If a circumcision hasn't been performed, the inner preputial skin can also be used. If it has been performed, usually there's enough skin redundancy on the shaft if this flap is possible. So the distal incision is made down to the anterior lamella of Buck's fascia, sorry, as you can still see in the first picture. And then the proximal incision is made deep to the level of the skin and into the dartos fascia so that you can again split it for 2 blood supplies, one to the flap and one to the overlying skin. The pedicle to the skin flap is then mobilized down to the level of the penile base, which is very important in order to prevent penile torsion with erection, and it allows easy rotation of the flap. The circular flap is then divided ventrally or dorsally. It's then rotated and positioned vertically and then sewn in place to cover the urethrotomy that was made over the stricture, and this is sewed over a Foley catheter. The skin is then closed, and what you're left with is a circumcision scar. Success rate of this procedure has been reported to be 90% at a follow-up of 96.7 months in the literature. So now to talk about grafts. Throughout the evolution of substitution urethroplasty, many different graft materials have been used, including scrotal skin, extragenital skin, even bladder mucosa, colonic mucosa, lip and linguinal mucosa, and of course buccal mucosa. These grafts are now used almost exclusively and are considered the gold standard for graft reconstruction in the urethra. Buccal mucosa grafts are ideal because they're readily available in all patients. They have a concealed donor site, little morbidity after harvest, and virtually no long-term morbidity. They're hairless and compatible in a wet environment and have a vascular thin lamina propria which can facilitate graft take, as well as an elastin-rich epithelium, making them quite durable. Relevant surgical anatomy are to identify and preserve Stenson's duct, which originates from the parotid gland and exits as a papilla, which is just adjacent to the second maxillary molar. The second very important structure is the buccinator muscle, which is deep to the buccal mucosa. This needs to be preserved and not injured during the graft harvest because it can result in poor wound closure and even facial muscle dysfunction. So as a urologist now operating in the mouth, we need to remember to examine our patients in the mouth to look at their buccal mucosa before proceeding with these procedures, as there are known relative and absolute contraindications to harvesting these grafts. Some of the conditions are seen here. So on the left you see oral lichen planus, in the middle an aphthous ulcer, and on the right side pemphigus vulgaris. As well, a thorough social history needs to be elicited, screening for high alcohol use or heavy smoking history, as these both can induce dysplastic changes in the mouth, and they are contraindications to harvesting a buccal graft. When in doubt, you can consult a dentist to look in the mouth. So buccal graft harvest, to briefly review the technique, a surgical marking pen is used to outline the extent of the graft. We stay several millimeters away from Stenson's duct, and then local anesthetic is injected to hydrodissect the layers from the underlying muscle tissue. The graft is then incised with a scalpel, and the incision is limited to the full thickness of the mucosa. You create your dissection plane through the submucosal adipose tissue layer, superficial to the buccinator muscle. Primary closure is accomplished with a single layer of 4-0 absorbable sutures, usually in a running fashion, and then the graft is put into normal saline and is then stretched either here on a hard surface or over the surgeon's finger, and then any excess fat or muscle fibers are then trimmed from the graft, and it's ready to use. So there are 4 substitution urethroplasty techniques which use buccal mucosal grafts, and I'll talk about them. They're the Asopa technique, Barbagley technique, ventral graft urethroplasty, and the pulmonitary technique. So in the Asopa technique, the penis is degloved, and a ventral urethrotomy is made to expose the stricture. Through the ventral urethrotomy, the exposed dorsal urethra is then incised in the midline, and the 2 sides of the urethral plate are mobilized laterally, A buccal graft is then placed in the dorsal opening of the urethral plate as an onlay graft, and then it's sutured to the mucosal edges of the urethral plate. You place quilting sutures, and then a Foley catheter is placed, and the urethra is retubularized. Advantages of this technique are non-circumferential mobilization of the urethra, so you are preserving any circumflex or perforating arteries to the spongiosum. Disadvantages are that the urethral plate does need to be at least 1 centimeter wide, and the width of the buccal mucosal graft that can then be inlaid into that is sometimes relatively narrow compared to some other grafts, which I'll talk about. The Barbagli technique, which is quite commonly used, is a dorsal graft onlay urethroplasty. It involves full mobilization of the urethra and rotating it 180 degrees, so you make a dorsal urethrotomy over the stricture. And then a buccal mucosal graft sized to the length of the urethrotomy is then quilted to the corpus cavernosa and sutured at both ends. The urethra is then rotated back to its original position, covering the graft area. Advantages of this procedure are that in the bulbar region, the urethra anatomically is displaced more dorsally, so that when you are making your dorsal urethrotomy, there is a lower risk of significant bleeding from that, and as well the suture lines are non-overlapping. Okay, so ventral onlay graft. This is usually performed for mid or proximal bulbar urethral strictures because the bulb is sufficiently wide in these areas for adequate spongioplasty. So the stricture is incised in the ventral midline, catheter is placed, and a ventral onlay buccal mucosal graft is sutured to the lateral borders of the urethral plate. Spongioplasty is then performed as secondary closure. But for ventral grafts, it's very important to size the graft appropriately and not make it too large because there is a risk of forming a diverticulum. So to compare dorsal versus ventral onlay graft, a meta-analysis by Wang compared these two buccal mucosal graft techniques and revealed a similar success rate between the two, 89% for dorsal, 87.6% for ventral. In a more recent review by Manjera further noted similar success rates, around 88%. This was at 3 years of follow-up for both grafts. Both have served, and stood the test of time and have similar success rates, but some groups do feel that dorsal stricturotomy and patch is better than the ventral due to the complications of ventral outpoaching or diverticularization that don't occur with the dorsal patching because you have that robust supportive corporal tissue behind it. Long-term restricture rates are not significantly different for these techniques, and they're about 10 to 15%.
Hilary, I think this is mainly for bulbar stricture.
Bulbar, yeah.
Penile stricture, ventral really doesn't work that well for penile strictures because there is no bed.
Yeah.
It's just your dartles. But here you have a spongiosum that can, it's your recipient bed.
Yeah, absolutely. Okay. In the end, it does come down to surgeon expertise, comfort level, and their personal success with one technique over the other. So the Paul-Minateri technique is for tight strictures of the bulbar urethra where the urethral plate is narrow such that a single graft would be insufficient to reconstruct the lumen of a reasonable diameter. In this case, you use both a dorsal and a ventral buccal mucosal graft. So a midline ventral urethrotomy is made, followed by a dorsal inlay grafting using a buccal mucosal graft, and then the urethra is then also grafted ventrally with an additional graft and then covered with a thick ventral spongiosum for spongioplasty. Essentially, this is a combination of the ASOPA technique and ventral onlay urethroplasty. So compared to anastomotic urethroplasty, which is often performed in the bulbar urethra, that does involve full transection of the urethra to excise the stricture. This technique of double grafting for a very tight stricture does better preserve that urethral plate blood supply. However, it does also demand more of the urethral plate for graft take. So it's a fine balance and often up to the decision of the surgeon. There have been no randomized trials which compare this technique to other forms of urethroplasty, but Paul Minateri himself and his group have reported a 90% success rate for medium-length strictures in the bulbar urethra. So for augmented anastomotic urethroplasty, it is possible to combine the two techniques of anastomotic urethroplasty and augmentation. This would be used in a situation to treat an obliterative stricture or very near obliterative stricture in the bulbar urethra where you want to excise the tightest portion of the stricture. Again, it's involving transection of the urethra transversely, so if the patient does have any conditions where the tissue isn't great, for example, lichen sclerosis or previous hypospadias repair, prior radiation, this probably isn't the best choice. It would be better to proceed with a graft in either a 1 or 2 stage repair. But this can be good in an otherwise healthy urethra with a very tight stricture in the bulbar urethra. So in properly selected patients, this is a single-stage urethroplasty repair, and it has been reported to have a 93% stricture-free rate at 28 months. So finally, the last technique I'll discuss is the staged urethroplasty. So two-stage reconstruction is considered whenever there's concern about adequate urethral plate tissue or subcutaneous tissue for secondary closure that would not allow for a successful one-stage procedure without tension. Other factors to consider are those of local tissue adversity, like I've mentioned, so previous hypospadias repair, extensive lichen sclerosis, history of abscess, malignancy, fistula, radiation. These would all be better served with a two-stage repair. So in the first stage urethroplasty involves complete excision of the strictured segment, followed by an onlay buccal graft. The second stage is tubularization, and this only proceeds after adequate healing from the first stage, which usually takes about 6 months. A transurethral catheter is inserted. The previous graft site is incised and mobilized laterally, and then the buccal graft is tubularized over a catheter, followed by secondary closure of the subcutaneous tissues, and then the skin layer. So finally, to discuss surgical outcomes, the first issue is how to define success and failure after urethroplasty. The literature does struggle to come up with a good definition of this, which Dr. Gleave already picked up on, so I will just touch a bit more on that. So there are many examples of failure post-urethroplasty that are used in the literature, and these are quite a heterogeneous group with a very wide range. For example, recurrence avoiding symptoms, radiographic recurrence of stricture, uroflow changes or specific flow rates, inability to devoid, decreased stream caliber. There's a whole range of these, and this does make it difficult to compare studies because they do have different definitions of their endpoints. Clinically relevant definitions of failure would be a patient who has recurrence of bothersome lower urinary tract symptoms, failure to empty, recurrent urinary tract infections, or urinary retention. So predictors of urethroplasty failure. Urethroplasty does give patients with anterior strictures the highest chance of cure. However, it can be quite an extensive procedure and can ultimately fail. And there's been 2 large studies that look at predictors of failure. The first was by Breyer, who had 448 patients at a follow-up of almost 6 years. They defined their stricture recurrence as any need for subsequent urethral intervention and found on multivariate analysis that smoking, prior urethroplasty, and prior endoscopic management were all independent predictors of subsequent failure. The second was by Kinnaird and Rourke from U of A, who looked at 604 urethroplasties at a follow-up of 4.3 years. They defined their failure or stricture recurrence as size less than 16 French on cystoscopy, and their analysis revealed independent predictors of failure being stricture length over 5 centimeters, lichen sclerosis, or any iatrogenic or infectious cause. So DVIU versus urethroplasty. In a recent review article by Aldrich compared these 2 techniques. They found the cost effectiveness of urethroplasty compared with DVIU suggests there's no advantage in doing more than 1 urethrotomy before proceeding with urethroplasty. They made the important point that a patient who comes to you with a significant stricture, and of course there's no unified definition for that, but there are certain patients with bad strictures who would benefit to go directly to urethroplasty and not undergo a DVIU at all. For short, previously untreated bulbar urethral strictures, they do quote about a 50% chance of cure with one dilation procedure or urethrotomy, but they argue that for those patients who fail that first procedure, they should proceed directly to urethroplasty as it provides a much higher chance of predictable cure. Finally, long-term success rates are high for urethroplasty, quoted in the literature multiple times between 85 to 90%.
So this slide right here is the take-home message
Yeah.
for trainees.
For sure.
Because there's still way too many DVIUs being done in the province. If you look at I get the payment series from the ministry,
Yeah.
and I'm always astounded that with the availability of the skill set to do urethroplasty well in this province, and you're doing flexible Cisco, you scope the patient, there's a stricture there, back out, talk to the patient. Who's the doctor? Who's the patient? Your job is to go and tell the patient, listen, these are the options. Don't rush to doing a DVIU. We've had 2 retirements of senior guys at this hospital who are not Dr. Wright, and the number of DVIUs has plummeted, which is good.
Yeah.
You don't do this to patients.
Yeah, absolutely.
And you know, like I said, you're doing a flexible Cisco, still bill a Cisco, get out of Dodge, send them to Danny or to somebody else, and get the patient properly treated.
Absolutely. Yeah, for sure. I can provide Danny Rappaport's fax number at the end of this if anyone's interested. So the next thing to talk about is grafts versus flaps. Initially, the choice of a graft versus a flap was a source of a lot of controversy in the field of reconstructive urology. The first prospective randomized trial comparing the 2 techniques was performed by Dubé, who compared buccal mucosal graft to penile skin flaps in 55 patients for anterior strictures. They found equivalent success rates between the 2 groups. However, the penile flap procedures were more technically complex. They were associated with higher morbidity, and they overall were less preferred by patients compared to buccal mucosal grafts. This was also supported, sorry for the small text there, by findings of Zhu and Wood, who found basically the same results, is that there was equal success rate, but overall the grafts had a higher ease of harvest, more reliable take, better regenerative capacity of the donor site, with fewer complications, and the patients preferred them. This all boils down to what is the best technique for urethroplasty. There was a review paper published in the European Journal of Urology in 2008 which ventured to answer this question by reviewing all of the literature results that were available at that time. And these were their conclusions. So for a short bulbar stricture, the best approach is an anastomotic urethroplasty. If the stricture is slightly longer and a simple anastomotic urethroplasty can't be achieved without tension, then you can consider the augmented anastomotic urethroplasty with a buccal graft. Knowing when to augment versus not can be a difficult decision, but they said if in doubt, use a graft to augment in order to minimize any tension. For a long bulbar stricture, they recommended a dorsal onlay urethroplasty, for example, the Barbagley technique, which I reviewed. So for penile urethral strictures, we must keep in mind that the surgery is more technically challenging than bulbar surgery due to the risk of graft contracture, which can lead to penile curvature. That can be due to infection or technical complications of sewing the graft too tight to the corpora. And for the penile urethra, the Orandi technique is useful for non-obliterative strictures that are not due to lichen sclerosis. You can use a flap. The treatment of penile strictures as a result of lichen sclerosis or following previous hypospadias repair often needs to be individualized, and again, this will boil down to surgeon expertise. But the general principle is to excise the strictured segment, and this often will be replaced with a buccal graft in either a 1 or 2 stage procedure, depending on the patient. And they quote in this article that it's still as much of an art as it is a science. So in conclusion, we've reviewed the presentation, etiology, diagnosis, and anatomy of strictures, the various surgical techniques, and presented some of the literature on success rates and outlined some recommendations. And I'd really like to thank Dr. Rappaport and Dr. Zapovina for their help in preparing this presentation. And thank you for listening.